important differential is fixed drug eruption. Because for this one, you will see most of the changes you can find in the erythema multiforme. Like we can see maybe lichenoid, but when I zoom in, you can see really clear vacuolar changes. And for the fixed drug, you can see these acute changes. What is the mechanism for fixed drug? That means when the patient takes some drug and then they have some allergy reaction to that drug, just like the mechanism of erythema multiforme. But one weird thing is that, for example, if the first time the patient take doxycycline and then they have this fixed drug reaction, it happened maybe in the dorsal hand or maybe palm and sole, and for example, maybe in the thumb. And then the patient have this itching lesion, but they do not pay attention to it, then this lesion just gone. And then the patient take doxycycline maybe for another reason, maybe Lyme disease, take doxycycline again. And then the same lesion happened in the same area, like also in the thumb. And then it happened again and again until the patient go to see the dermatologist, and then the dermatologist want to take the biopsy. That is the fixed drug. So the reason I try to tell you about this mechanism, because high power we can see these vacuolar changes, just like what we can see in the erythema multiforme. We also can see these dying keratinocytes everywhere, and even some eosinophil in the dermis. But one changes is that you can see this heavily pigment dropout. That means because the lymphocyte try to attack this DEJ junction, so the melanocyte and the keratinocyte just dying, they just drop this pigment into the dermis. That tell you these changes happen again and again. We call these chronic changes. So when you see this pigment dropout, vacuolar interface, that is usually not erythema multiforme. This is the fixed drug eruption. But you also need to pay attention. If this is Africa America, that means this patient had dark skin. So even maybe one time, this lymphocyte try to attack the DEJ junction, they have some pigment dropout. One of the definitive thing help you to tell them apart that this pigment dropout in the fixed drug, it need to deeper. What does that mean, deeper? That means this pigment, it need to lower than this capillary, lower than this vein. That is really chronic changes. Because one attack, the pigment maybe stay here. The other attack, the pigment will go down and down until they go lower than this vein. So, and then you will think that this is the fixed drug eruption, not erythema multiforme. But again, still really tough diagnosis if you want to make between these two. This is another fixed drug eruption. So here you can even see a blister here because the lymphocyte tried to attack this DEJ junction for multiple times, and then the whole thing just forming this split. But let's see this one. We can still see really clear dermis, lymphocyte infiltration. Then high power, we can see tons of these dying keratinocytes. This is our civar body, vacuolar interface changes. And then our friend pigment dropout is here, really low. Tons of pigment dropout. Also, we can see some eosinophil. Oh, and then I want to pay attention is that eosinophil is always related to drug. So if you see eosinophil, when we sign out, we always say, because we find eosinophil, we just could not exclude drug. Always bear in mind, when you say eosinophil, whatever other changes, drug is just could not be ruled out. So this is another case for the fixed drug eruption.